So, good evening, guys. Welcome to this live session. Where I'll be discussing NEET PG tips. Dr. Sudhanshu Ranjan, good evening. Hello. So let me introduce myself to you guys. Am I visible and audible, everyone? All of a sudden, I can't see myself. Just give me a second. Yes, so Dr. Himanshu, Dr. Sudhanshu, good evening, everyone. My name is Dr. Vinish. Presently, I'm the head of the department and senior consultant of anesthesia and critical care working with the Fortis Lafayette Hospital, New Delhi. I'm also a faculty and anesthesia educator. Right? I've been teaching anesthesia for the last 14 years now. So today, what we are going to be discussing is about the preparation for the NEET PG. Dr. Dushyant says, sir, I passed FMGE just now in first attempt. Please guide how to start, where to start for PG. Is my screen visible, guys? Is my screen visible? Just give me a second. Just give me a second. Dr. Himanshu saying, no, I'm visible, but the PPT that I have, that is not visible. Just give me a second, guys. Just give me a second. Just give me a second, guys. Just give me a second. Yeah, chalo. Now audible and visible, everyone? Dr. Dushyant, Dr. Himanshu. ठीक है? Yes, guys. Yes, so Dr. Sudhanshu says yes. Right. So let's start with the session, guys. So as I was saying, my name is Dr. Vinish. Presently, I am the head of the department, senior consultant of anesthesia and critical care. I'm working with the Fortis Lafayette Hospital in New Delhi. Also, I've been an anesthesia educator. I teach anesthesia. I've been teaching there for the last 14 years now. Okay. So today's session is with the preparation strategy for anesthesia. My point would be to focus about the topics that you need to do on anesthesia, where you need to focus about anesthesia and how it is important with other subjects integration. First, Dr. Dushyant is asking me, sir, I passed FMGE just now in first attempt. Please guide how to start, where to start for PG. So Dr. Dushyant, for answering Dr. Dushyant's question first. Dr. Dushyant is asking me, he has just cleared his FMGE. He wants to start preparing for NEET PG, right? He wants to start preparing for NEET PG. So the point is, since he has just cleared FMGE, Dr. Dushyant, your subjects are well prepared. You have already read all the subjects one for FMGE. But remember, as we have said, concept building is the most important thing. Whether you give FMGE, you give NEET PG, or you give INI-CET. Either of that, your concepts are important and the concepts remain same whether you give your FMGE, NEET PG, or INI-CET. The point is, since you have cleared your FMGE right now, just to immediately open the book becomes slightly difficult. What I would suggest, my thinking, and remember, everyone else will suggest to you different things. My point would be that you can start going initially with MCQ questions just to test your knowledge, right? We do the same thing for students. We tell students also, initially you start doing MCQs, take an MCQs, or maybe take a grand test because you have already given your FMGE and your memory is fresh with the questions. Solve MCQs and see how you are faring. Give a grand test and see how you are faring, so that now you have an idea. See, till now you gave questions related to FMGE. Topics are almost the same. But remember, in FMGE, there was no negative marking. As soon as you start preparing for NEET PG and INI-CET, remember guys, the biggest problem here now that starts different from FMGE is that you start having negative marking, right? So therefore you have to be careful, but MCQs and questions remain the same. This helps you to understand where do you stand. Okay, where do you stand in comparison? So solve your MCQs, start with your GT and look at your weak subjects. Even during your FMGE, you must have realized there are some subjects which are weak, right? So look at your weak subjects, right? And as we always say, pay attention to them. So therefore you start solving MCQs. Another important point is when you're solving MCQs, remember the retrospective part. Retrospective means you solve your MCQs if your answers are absolutely correct. In this case, go ahead with that, don't worry about it. But in case if you get confused or if your answers are wrong, in this case, you need to go back and read your concepts again to understand where you went wrong, right? Dr. Praveen Prasad says eco. Achha, eco, sorry. Eco. Is it okay now? Dr. Praveen? Is it okay? Hopefully that Dr. Devu says, sir, kuch padha do aaj important topics. Actually, see, more than teaching na, today I want to discuss about the topics. Otherwise, we'll come again. Dr. Chiku says, sahi hai, sir. Are good name, huh? Dr. Chiku. I like that. Good name. Right? So now I'm just going to discuss actually the topics which are important. Same for all the students who are around, guys. All the people who are preparing from anesthesia. Or I mean for the entrance, NEET PG and INI-CET. I would rather say, how do you go about for anesthesia? What are the topics which are important and what do you need to concentrate upon? So let's start with the first thing, which is pre-anesthetic checkup. Pre-anesthetic checkup wo hota hai, it is something which is done before the patient comes for the surgery. So therefore in pre-anesthetic checkup, remember there are 3-4 things which become very important. The first thing that you need to see is that ASA grading, American Society of Anesthesiologists grading, which is 1, 2, 3, 4, 5, and 6. Or this becomes a very important part. Pay attention to it. You need to study that. After that, what becomes important is before the surgery, what are the medications? Patient might be on some medicines, based on your grading of ASA. The patient may be on some medical history, the patient may be on some medicines. What medicines to stop? What medicines to continue? Basically the medication advice which is given to the patient, that becomes important. For example, you must have heard aspirin, stopped, not stopped. You must have heard clopidogrel, warfarin, all these drugs which are stopped before surgery. This becomes an important point. Medication advice before surgery, right? These two things are absolutely important from pre-anesthetic checkup. Before the patient comes inside the OT and we give a medication, remember the pre-medication drugs. Pre-medication drugs are drugs like glycopyrrolate, which are given to decrease secretions, right? Other drugs which are given like antibiotics. So all these drugs which are given before the surgery, they form an important part which you are supposed to know, right? Pre-medication drugs. So pre-anesthetic checkup is the first thing. Pre-medication. When I'm discussing pre-anesthetic checkup, a very important point here becomes something called as airway examination. Now, airway examination I'm writing separately because we need to do airway management also. Airway examination means whenever you're going to give anesthesia to a patient. Yes, in general anesthesia, we will intubate. When you give general anesthesia, you are supposed to intubate, you do a bag mask ventilation, or you do a laryngeal mask airway, either of that, right? In spinal, you're not going to do that. Spinal or epidural, you're not going to put an endotracheal tube. But in spite, other than the fact that, in spinal or epidural, you're not putting endotracheal tube, still the airway examination is supposed to be done because by chance you have a complication of spinal or epidural, you will need to handle the airway of the patient. Airway examination includes different predictors of airway examination, okay, predictors of difficult airway. And important point here inside predictors would be Malam Patti grading, okay, MPC or Malam Patti grading, okay, yes. So Malam Patti grading on predictors of difficult airway examination, this becomes important, right? Beyond that, Now you need to know individual drugs, individual things which are given for general anesthesia, individual drugs for spinal anesthesia. These are the types of anesthesia. So when we come to drugs, let's classify the drugs into two types. You have to study the drugs which are given for general anesthesia, and then you have to study for spinal or epidural. So when you speak of general anesthesia, guys, you need to study these induction agents or induction drugs. The induction drugs would be including the inhalational agents and the IV induction agents. So the inhalational agents which are there, that is sevoflurane, desflurane, isoflurane, halothane, you need to study their properties, individual properties like minimum alveolar concentration, right? Oil gas solubility, blood gas solubility. Then IV drugs is what we are supposed to know, which is thiopentone, propofol, ketamine, etomidate. All these drugs we are supposed to know, right? Apart from that, as I said, other drugs go into pre-medication drugs. The drugs like opioids, they can be included anywhere. They take care of the pain. So if you will see, these are the induction drugs. You need to know all the drugs that take care of analgesia also for general anesthesia. This would include drugs like opioids. This would also include alpha-2 agonists. These are co-induction agents, right? We'll rather call them as co-induction agents. So you can have benzodiazepines, you can have alpha-2 agonist, this group of drug. Now, apart from this, you need to know muscle relaxants, which becomes very important for general anesthesia. These are the drugs which paralyze the patient. So muscle relaxants, you have the depolarizing muscle relaxant and the non-depolarizing muscle relaxant. So when you speak of general anesthesia, this is the pharmacology of the drugs which are used. Pharmacology of the general anesthesia drugs. Similarly, if I have to discuss pharmacology of the local anesthesia drugs, that itself becomes an important topic. Local anesthesia drugs and their pharmacology. Pharmacology means how these drugs are working. So mechanism of action, where they are working, the various properties of the drugs, the classification, various uses, right? So the mechanism, properties, classification, and uses. You need to know this when we are discussing local anesthesia, right? Local anesthesia pharma. And the same local anesthesia drugs are then used for spinal, epidural, and blocks. So now, when you speak of spinal, when you speak of epidural, the important point is these are your central neuraxial block, which are given in the central nerves of the body. Central neuraxial block. So when you speak of spinal and epidural, you are supposed to know the anatomy, the way that it's being given. You need to know how it works, right? The site of action. You need to know the types of needles which are used. Apart from that, how it's working. What are the physiological effects? What are the side effects? What are the complications? And what are the contraindications? So this is about spinal epidural when you're discussing. You also need to have a slight idea about blocks. Blocks, you don't need to study all of them, but yes, 2 or 3 blocks which are important, like brachial plexus block. Okay, brachial plexus block. Apart from that, there are another 1 or 2 blocks which you should be knowing, like stellate ganglion, celiac plexus. So these are various blocks that you are supposed to be aware of. So till now we have seen pre-anesthetic checkup is an important topic, pre-medication, airway examination, the pharmacology of general anesthesia drugs is what we saw, right? Then we saw about the pharmacology of local anesthesia drugs, spinal epidural, various blocks, right? Along with that, you are also supposed to know, now when you give general anesthesia, you're going to take care of the airway also. So therefore now airway management becomes a very important part. So when you speak of airway management, guys, remember you're supposed to be knowing laryngoscopy and intubation well. So then you need to know laryngoscopy and intubation. I'm just discussing the topics of anesthesia, guys, right? In laryngoscopy, intubation. Apart from that, bag mask ventilation, laryngeal mask airway, right? Oropharyngeal, all these, oropharyngeal airway, nasopharyngeal airway, bag mask ventilation. All this become very important when we are discussing about the airway management, when you are handling the airway of the patient. Okay. After this, once you're done with these parts, remember, important thing is regarding CPR. Okay. CPR becomes very, very important. Okay. And CPR, ideally, BLS is something we are supposed to know absolutely well, because questions do come on BLS. And ALS is something where you need to have about the idea of important topics. Recently, they have been asking a lot of questions regarding the chain of survival. They've asked this in FMG exam. It's a very small thing, but they have asked this. And in INI-CET, they specifically they've paid attention, or they've asked questions regarding the post-cardiac arrest care. After the patient has been revived, what you're supposed to do. So these two topics they had not asked before, but recently this is where they are focused upon, post-cardiac arrest care. These two are relatively newer topics where they are focusing upon. Initially, BLS and ALS was where all the questions were asked. Sir, in emergency, which is the most appropriate tracheostomy or cricothyroidotomy, says Dr. Chiku. Okay, so the point is, as Dr. Chiku says, in emergency, guys, remember, in emergency, okay, one more point. So when we are discussing emergency, you do not have time, guys. If you do not have time, the point is, in emergency, you either go for oral endotracheal intubation, and if you do not have time, of course, then there is cricothyroidotomy can be done. Cricothyroidotomy. And remember, it can be of two types, surgical or needle, right? And the point is, why not tracheostomy? Because, guys, in emergency, if a patient is dying, you have to take care of the airway and save the life of the patient. When you do tracheostomy, how much ever fast you are, in tracheostomy, you're supposed to cut the rings of the trachea. You have to control that bleeding and then put an endotracheal tube. How much ever you take time, tracheostomy will take minimum 5 minutes, minimum 5 to 8 minutes. Remember, endotracheal intubation can be done within 10 to 15 seconds in case of an emergency life-saving procedure. And same thing goes with cricothyroidotomy. Therefore, in case of an emergency, oral endotracheal intubation is the best thing, or cricothyroidotomy. Otherwise, if you have time, it's an elective airway management. If it is an elective airway management, you can do tracheostomy or you can do nasal endotracheal, depending as to where the injury is there. Nasal endotracheal can also be done. Yes, Dr. Chiku? Yes, so that answer hopefully is an okay thing. Dr. Chiku? Good name. Right? Any other doubts, guys? Please ask me. Any other doubts? Ask me anything, sort of. Hopefully, I should be able to answer. Sir, in BLS, should we check for pulse or respiration simultaneously? Good question, Dr. Arundhati. Now, according to BLS guidelines, remember the first step they say is scene safety. Scene safety is the first step. The second step after that is check for response. This is the second step. After check for response, the third step is call for help. These are the first three things where you have not checked the pulse and BP, the pulse and breathing till now. These are the first three steps of BLS. Scene safety, check response, call for help. So that, people can get that automated external defibrillator or, equipments to help you. Fourth step is where you check for the way it is mentioned in the books. Check for pulse and check for breath. And the word written is simultaneously. Simultaneously means you are putting the hand on the carotid. They say put your hand on the carotid, and while you put the hand on the carotid, at the same time look at the visible chest rise. This is what has been mentioned. And remember, this pulse check has to be finished within 10 seconds, maximum 10 seconds. Right? Maximum 10 seconds. So therefore, pulse and breath is checked simultaneously within 10 seconds. So pulse, carotid, you keep your finger on the pulse. At the same time, look for the visible chest rise. And now, once you feel the pulse or the breath, then depending as to what are the situation, you go into three parts. If both pulse and breath is present, if you get both pulse and breath present, pulse also present, breath also present, keep the patient in the recovery position. If pulse is present, breath is absent, in this case, you're supposed to give breath to the patient because breath is absent. And in the third scenario, when pulse is absent and breath is absent, this is where you start the CPR with CAB. This is your how BLS goes away. Right, Dr. Arundhati? Hopefully this point is clear. Right? BLS. These are the basic steps of BLS. And once you get defibrillator, the next step is you add defib. Once you get a defibrillator, then you add a defib. These are the steps of basic life support. Dr. Neil says difference between sleep and anesthesia. Okay. So difference between sleep and anesthesia is, let me put it this way. If you know about EEG, So EEG pattern, normally you have first when you slightly, not sedated, but your brain is slightly going down. It is the beta waves, followed by the alpha, followed by the theta, and followed by the delta. Delta waves are supposed to be deep kind of waves, right? This is what is there. So when you are sleeping, so these are the various stages, and the various EEG wave, the brain activity which you see, beta, alpha, theta, and delta. This is what is called as deep. This is where the anesthesia is. So that's exactly why we say bispectral index. That bispectral index tells us the same thing. Between 100 and 0. At 100, the patient is awake. At 0, the patient is a flat line EEG or coma. Flat EEG. And as you people would be knowing, 40 to 60 is the value for general anesthesia. 60 to 80 is sedation. A normal patient, when he's sleeping, when you're talking of someone just staying at home, you are normally something like this, here, somewhere here. General anesthesia is deep, right? It's a deeper plane. So this is what is the difference between that. So this is how we check in terms of patients also. This exactly is what is called as depth of anesthesia monitor, or which is called as bispectral index. Dr. Nil, is that okay? Difference between sleep and anesthesia. So basically, when you're giving anesthesia, the patient is going down one by one. Initially, the patient is awake. Then the patient goes off to slightly sedated. After sedated, the patient is sleeping. Then the patient goes into deep sleep. And then there is the state of hypnosis. Then state of general anesthesia. And if you don't stop there, it may lead to coma and it will lead to death, which is overdose of anesthesia. Dr. Nil, hopefully the point is clear. Anyone else? Otherwise, let me finish off what I was discussing before this. Hopefully these points are clear. Dr. Nil ne answer nahi kiya. I was waiting for his answer. Okay. So Dr. Chiku I answered. Dr. Arundhati answered. Dr. Chiku says, sir, please tell about MD anesthesia scope. And Dr. Neil says about recurarization. Okay. Let's finish off one by one. So let's finish off as Dr. Chiku is saying. Sir, please tell about MD anesthesia. MD anesthesia scope. It's good, yeah. It depends. If always the advice to any person who's picking up anesthesia is, remember, you have to be interested in the branch, right? If you are interested in surgery, if you are interested in medicine, remember, don't pick up anesthesia. Simple. If you want to look at a OPD practice, or if you are, very good at cutting. In Bombay, we used to call cutting. Mumbai, cutting is what? When you're doing a procedure. If you're very, very good with procedures and you want to handle the patient directly, or maybe operate a patient. If you want to operate the patient, remember, never ever pick up anesthesia. You will be frustrated throughout your life. If you like a OPD practice, you like patient touch, in the sense that, you like the patient returning back to you into the OPD, telling you that, doctor, I'm feeling well, I'm feeling good, and you get a validation from the patient. Don't pick up anesthesia. You will never be happy. The problem with anesthesia is that the patient does not return to you. Okay. You are there in the OT. It is a clinical branch. You will be doing your procedure. But after that, the patient is done. Remember, the patient tends to forget you. Because the patient forgets you, the patient does not return to you. Therefore, the validation that you think the patient might give you does not take place. Okay. So that is why this is the point. People interested in medicine and surgery, don't take up anesthesia. What is the scope of MD anesthesia? Guys, scope is there for all the branch. If you are interested, you will like it. Not only you will like it, you will tell your juniors also to take the branch, right? In terms of scope, let me tell you that anesthesia people are required everywhere in the hospital. You would think that anesthesia people are needed only in the OT. Okay, let's talk about the OT. Just think about your hospital where you're working. How many OTs are there? You get a main OT or a general OT, which is a surgery OT. After surgery OT, you get a you have a gynae, obs gynae OT, right? Obs gynae, you have orthopedics, you have ENT, you have ophthalm, and all the super specialties of surgery, right? All the super specialties of surgery, which is plastic surgery, which is neurosurgery, which is cardiac surgery, which is gastrosurgery, gastrointestinal, right? So these are your super specialties: ortho, ENT, ophthalm. This is what I've spoken just about the OT. In fact, nowadays in gynae, there's a separate IVF OT also. You get a separate IVF OT in gynae. Even that is there. उसके आगे Dr. Virendra Pratap says, Karam market भूल जाओ. करम मार्केट मतलब मार्केट भूल जाओ, मतलब ठीक है, मतलब इफ यू आर सेइंग इन दैट सेंस यू नो कि कोई पेशेंट विल नॉट रिमेंबर यू, तो वो बात में तो है, बट आई एम टेलिंग यू इन द नीड ऑफ द हॉस्पिटल। सी पेशेंट विल फॉरगेट, करेक्ट, करम करो और भूल जाओ, सॉर्ट ऑफ। हाँ, आई अंडरस्टूड योर पॉइंट डॉक्टर वीरेंद्र, करेक्ट, मतलब you have given your anesthesia and the patient forgets you, correct, but the point is guys, the anesthesia person becomes the most important person in the hospital. Apart from OT, you are handling the ICU. Apart from ICU, remember your services are required in the CT scan and MRI also. CT and MRI, you need your service in the MRI suite. Apart from that, you will be needed in emergency and casualty at any time of time. Some places casualty is given to anesthesia, but otherwise nowadays emergency medicine is what is handling the emergency department. I got it, Dr. Virendra, I got it. Karke, I got your point. Right, you said the same thing. So therefore, so OT mein you're needed, ICU mein you're needed, CT scan, MRI mein you're needed, emergency and casualty mein you're needed, right? These are the places. Even in psychiatry, guys, I don't, nowadays they're not doing it, but initially when I was doing my PG, that time in psychiatry, when we used to give electroconvulsive therapy, you're needed there. Achha, I forgot one more thing. Forget all this. This is about OT. This is about ICU, CT, MRI, out of OT anesthesia, emergency, casualty. Guys, do you know anesthesia people are also needed in medicine super specialty like angiography, angioplasty? You are giving your services there also. You are there for conscious sedation, right? For angiography, they're supposed to be standby. I'm not saying they're doing any procedure. Anesthesia people are standby for angiography. They are standby, or they are giving sedation for various types of endoscopy. So various kind of diagnostic procedures, it's the anesthesia people who are there as a standby, which you people don't think. Anesthesia people are needed for angiography, endoscopy also. Okay, so this is the scope of services inside the hospital. Now you imagine how many surgery PGs are there, how many gynec PGs are there, correct? You calculate how many PGs are there and how many people are there for plastic surgery, neuro. Just calculate and compare to that how many anesthesia seats are there. Think about it in your own hospital. If surgery postgraduates are 10, gynec postgraduates are maybe, you know, another 6 or 8. Let's take it 8. Orthopedics are again 8. ENT opthal are 4 and 4, right? If you take plastic surgery post-graduation, super specialty, there may be 4 seats. Neuro 4 seat, cardiac 4 seat, gastro 4 seat, right? Medicine, forget, let's not take it. Apart from that, psychiatry, you have 4 to 6. Imagine, forget all the other things, but if you are just calculating the number of surgeons passing out from one institute, surgeons, so 10, okay, around 20, 30, and 40, 50, maybe 40. At any, if you have the total number of surgeons, all the surgeons passing out, how many are anesthesia seats, guys? Maybe 15, maybe 20, at the max 20 seats from anesthesia. But every year, about 50 surgeons will pass out. On only 20 anesthesia people will pass out. Where is the balance? Can you see that? Yes. हाँ, डॉक्टर नील सेज पेन मैनेजमेंट, देखो मैं भूल गया, थैंक यू फॉर रिमाइंडिंग. पेन मैनेजमेंट, वेरी गुड. Pain management. In fact, when you're working in corporate hospitals, pain management becomes such an important topic. I mean, it's such an important point where pain management is separately handled by the anesthesia persons. Very good. Okay, so now the point is, if you are interested, scope of anesthesia is always there. Even in medicine, do you know, when you're working as a postgraduate, if someone, you know, I was told a lot for this also, but I always meant to say that, you know, see, all the specialties are needed for the hospital, but anesthesia people for the hospital are the backbone. Like if someone is unable to intubate, you are called. If someone is unable to put a spinal or maybe do a lumbar puncture, I am telling you, even for lumbar puncture, anesthesia persons are getting a call in hospitals. LP normally is done by medical people, right? I'm not saying they don't do it, they do it very well. But the point is that when it becomes difficult, anesthesia people are called for lumbar puncture also. They are called to intubate in the medicine ward also. They are called to insert the Ryle's tube also. Someone not getting an IV cannula, you're called to put an IV cannula, you're called to put a central line. You are doing all the procedures, but the point is, as very well said, that, you know, you get your job done and the patient forgets about you, that you have put the Ryle's tube, you have put the IV cannula, you have put the central line, you have done the lumbar puncture, because the treating doctor is going to be the medicine person or the surgery person, right? You are just there as a help. Think of anesthesia people as, you know, more of a, you've seen the movies, right? So medicine people and surgery people, they are the actors and the actresses, hero, heroine. Anesthesia people, right? Radiology. These people are the editors of the movie. They are pathology also. Let me put anesthesia, radio, and patho. Okay, so three branches. If you're making a movie, anesthesia, radiology, and pathology. So these branches, these people are going to be, like an editor of a movie. They are like a director of a movie. They are not in the forefront. They are at the back. They're doing some work related to the movie. But the people in the front basically are your orthopedic, gynae, orthopedic surgeons, normal surgeon, medicine persons. So these are the people who are the actresses. They are the actors. They are the one who get all the accolades. They get the accolades. But everyone who's making a movie knows that ultimately a director or an editor is as important as an actor or an actress. Okay. Okay, guys. So that is an important topic. So anyone who's picking up anesthesia, guys, remember, pick up only if you're interested. And if you don't know if you're interested or not, remember, you should not be interested in surgery. You should not be interested in medicine OPD branch. If you're keen on OPD branch where you want the patients should follow up with you, because there is no follow-up in anesthesia. So if you're interested in an OPD branch where you want a follow-up, remember, follow-up comes even in psychiatry. It comes in derma. All these branches have a follow-up. Anesthesia does not have a follow-up with patients. The patient will not follow up with you. In that case, do not pick up anesthesia. Okay. Yes, guys. So I was discussing the topics from anesthesia. We got deviated there. Let me finish off that first. So I discussed about all the topics which are there, right? So I told you about PSC, pre-medication drugs. I told you about airway examination. I told you about the general anesthesia pharmac. I told you about the local anesthesia pharmac. I told you about spinal epidural. I told you about the various blocks. I told you about airway management, CPR. Apart from CPR, guys, nowadays little questions or some questions from critical care are important. And more than anything else, what they ask about critical care, important questions are regarding the central line, arterial line, IV cannulation. Okay, arterial line, IV cannulation, and in fact, INI-CET, some questions are based on ventilators also. But when you're discussing ventilators, guys, remember, it's not just the ventilators which become important, but that whole point of oxygen delivery devices. So everything from oxygen delivery devices, that is important, right? Leading to CPAP and BiPAP, where questions are asked on CPAP and BiPAP. And finally, some questions or some part of ventilator, this becomes important. So this is regarding oxygen delivery devices, CPAP, BiPAP, and ventilators, right? Some points on ventilators. Apart from that, I hope I've not missed anything, but these, according to me, are the most important topics from anesthesia. They have to be studied. You have to study them, and they are all simple. The difficult ones to understand, according to me, is going to be CPAP, BiPAP, and ventilator. According to me, this is the most difficult, which most of you will find not very easy to understand. Okay, this is difficult. Oxygen delivery devices are easy, relatively. Critical care, as I said, ventilators are difficult. CPR is easy. Airway management, LMA, unless until many of you have used LMA, all of you find little bit difficult to understand because many people have not used and they have not seen. So LMA you might find difficult, but LMA is again an important topic, right? In terms of block, this becomes slightly difficult to understand because you don't understand exactly that where the blocks are given, right? Slightly difficult, though questions asked from here are less. Spinal epidural is easy, guys. Don't miss out on this. Don't make any mistakes in spinal epidural. Local anesthesia pharmac, anyways you study this in pharmac as well. All the faculty from pharmac teach local anesthesia also. So therefore, it gets covered in two places. Yes, general anesthesia is what gets covered normally in anesthesia completely, and you need to pay attention to this. Rest, these questions are also very, very simple. In short, when you're preparing for NEET PG, INI-CET, guys, this is an easy subject to tackle. You don't have to put in a lot of effort, but yes, you have to have your concepts clear. Okay. So guys, that is from my end. Anything else? Please let me know. So my point was just to give some idea about the topics which are there and which you should concentrate upon. And of course, we'll be coming back with more things as well, right? But this was a very small session, short session to discuss about the topics. Anyone else, guys? Anything else? Any other doubt? Yes. Okay, so let me see the Telegram also. I think I'm live on Telegram as well. I didn't see any question there. Anyone directly giving me answer there? Okay. So here also no texts, nothing. Right. Okay, guys. So thank you for joining me at this session. It was good interacting. All the best, guys. Join us for the further sessions also. Any questions and doubts you can direct to us. Okay. So take care. All the best. Study well and don't take tension. Right? You have to study well, but de-stress yourself. Have something to de-stress yourself. You know, it may be guitar, it may be music, it may be playing an instrument, it may be going for a dance, or whatever people like. Dr. Chiku, good night. Thank you. Thanks a lot. Okay. And any other questions, guys? So you can direct them to us, right? You can direct them to us. We'll be coming back with more sessions, guys. We'll be coming with more sessions. We'll be coming with MCQs. We'll be coming with more sessions in future. So don't worry. This was a very short interaction where I personally came up with some points regarding anesthesia, what you should concentrate upon, right? So take care, guys. All the best and do well. Signing off. Good night.